If I really had my key message that I want to make sure that we get through this today, is when we're talking about these risk factors, the most important thing about skin integrity is asking the two questions of how did the skin breakdown start and why isn't it healing? Because if you don't treat the skin breakdown as a total body thing, if you treat an ulcer as though it is a skin problem, it is going to just recur. It is not going to stay healed over, and it all becomes a vicious circle of a why bother. So the two key questions are, how did this wound start? Why isn't it healing? That would really be my TED Talk version of this. Thinking about what are the key points to consider and how do you really help your patients not get skin breakdown, you're going to advise them these few really practical things. Check your skin. The number of times I've had my folks tell me, oh, I check my skin every day. I run my hand over my backside. I don't feel anything. I'm good. That is not going to catch stage 1 pressure injuries. So it's better than nothing, like yay-ish. That's a yay-ish. But it's not good enough. So this is where cell phones can be super helpful as well, because our patients can actually use their cell phones, take pictures. They can have their deleted file as well, because you don't want it uploaded into the family cloud. But it really does give them another tool for being able to do skin checks. Another practical point is when you're in your offices, it can be very challenging, labor intensive. You might need extra hands. You may not have a plinth set up. You may not have an overhead lift. How is it that you're going to physically check skin for your patients? It can be either challenging, time-consuming, or even impossible. So this is where you can also ask your patients to bring photos in with them if they're talking about a wound. It may not be as ideal as in inspecting it yourself, but it is such an important tool to be able to do the skin checks. Why is it helpful to actually see the wound? Because the description of where it is really speaks to how come it started, and gives you that ability to look for the root cause of why is this happening and why is it happening now. The other thing is that the description of how big it is may be based on old information that they have. If you don't have sensation, you may not actually fully know the dimensions of the wound yourself. So skin checking, cell phones, photos, visually inspect when you can, because it matters for why it started and why it might not be healing. Weight shifting. So the classic way we think about weight shifting is to have people, if they're in a wheelchair where their ischial tuberosities are at risk, to do a seat lift. So putting your hands on the armrests and offloading the buttocks. Well, how long are you supposed to do that for? How often? Really, in order to get the adequate blood flow, you're looking at 45 seconds. That's a super long time for someone to be doing a seat lift. Just think of if you're in the gym doing triceps dips. Not necessarily easy or comfortable, especially if you have shoulder problems. What happens as you get older? The connective tissue architecture of your rotator cuff muscles changes, sadly, and you may have shoulder pain. So that may not be a realistic, practical way for people to do weight shifting. You can lean forward, get them to lean forward in their chair. That de-weights the ITs. They can do a side lean. That can help de-weight the contralateral side of the buttock area as well. If someone has power mobility, you're going to ask them to go into a tilt position. That redistributes the forces. The one thing I'm going to say is when you talk about weight shifting for folks who have tilt features in their chair, if you have someone in a 90-degree position and you get them to tilt to this point here, if you think of a vertically oriented force, that goes right down potentially through their tailbone, through the coccyx. So if you have someone who has a coccygeal pressure injury and they're like, but doc, I am offloading all the time. The problem might be that they are offloading all the time because they're not. So just be aware, again, that's where really knowing where the wound is and how people are weight shifting makes a difference for really getting to the root cause of why isn't it healing. Cleaning and drying skin properly after incontinent episodes. Again, that may be something that gets back to the root cause of have we figured out why a wound isn't healing? Well, what if it's always getting infected? Well, maybe that is because of fecal incontinence, or maybe it is because the ongoing shear forces and friction forces that are in areas that are wet and goopy and not resistant to that slide. Pressure redistribution. So we talk about seating a lot. It's like, well, my patient has a ride cushion, so they'll be fine with their ischial tuberosities. A ride cushion is a custom carved foam cushion that really takes all the pressure off the IT area. And it's kind of like if you're sitting on a toilet seat kind of feeling. One of the problems is that suspended feeling may not be well tolerated by someone who has a sensory incomplete injury, because it kind of feels like you're on a toilet all the time. So just be aware that that even things like weight changes. So if someone loses a lot of weight, they can sink further in and bottom out on their ride cushion. Or if they gain a lot of weight, they may not be getting that pressure relieving. So even when you think you have an ideal cushion for someone, it may not be any longer ideal. We're talking about other surfaces. So what happens when you're on a commode chair? That can be a place for sacral injury or skin breakdown. What about people who take baths and can't quite do a nice landing when they're getting into the tub and do that clunk at the bottom end? That may lead to skin breakdown. Speaking of shoulders, what if someone ends up with a supraspinatus tear? They can't reach around behind them very well anymore. They're doing these transfers going from side to side, and they now, instead of being able to have their buttocks go from the cushion onto their bed, they have to have a mid-transfer break where they bang down on their wheel every single time. It really could be that the reason they have a pressure injury is because of a shoulder problem. So again, it's always like root cause, root cause, root cause. Why did it start? Why now? And how do we treat the skin injury in that totality of how someone's managing? The challenging thing with skin integrity is that it requires the whole systemic review. That might be looking at things like spasticity management. Another example of getting to root cause. Let's say someone now has a back of their heel pressure injury. And you're thinking, why now? Well, it turns out that they're on their mattress, but they go into a hip flexor pattern of spasticity. And they're sliding their heel up and down the bed constantly in the overnight hours. Well, why now? So why do they have the spasticity now when it's been fine before? Well, I'll just put them on a pillow so that their heels are suspended off the bed, it'll be fine. No, they're still spastic, and the pillow gets shoved out of the way and they're sliding their heels across. Okay, well, why now? Well, maybe it's because they're actually having some urinary leaking and their bladder is really kind of grumpy, and really it might be because they have bladder stones. So their pressure injury may have actually happened because they have increased spasticity, because they have bladder stones, and they need to go see their urologist for the crush and flush. And that might be what really is the shifting for the ability to heal that wound.